to Affect Autism, where affect is the #1 tool we use in supporting child development through playful interactions.
Hello, I'm Daria Brown, and this week we have 3 guests. John Carpente is an expert DIR training leader, professor of music therapy at Molloy College, founder and director of the Rebecca Center for Music Therapy, and founding music therapist and creator of the DIR floor-based music therapy program at Rebecca School in New York City, where he participated in weekly supervision and case conferences with Dr. Stanley Greenspan. Welcome back, John. And we also have Galina Itzkevich, who is a clinical social worker in New York City and a clinical consultant with ICDL, the Interdisciplinary Council on Development and Learning, and a DIR expert training leader. She works with different clinical populations, including children and adults, both on the spectrum and neurotypical. And we have Dr. Beth Ammons, who is an MD in Montana, who has spent the last 18 years in hospice care, and she is working hard to add the element of palliative care. So why are we here today? We are here because we all attended the Interdisciplinary Council on Development and Learning's 2020 conference on Developmental Individual Differences Relationship-Based Model, DIR Floortime, and we watched a presentation that was entitled Prospects for the Use of DIR Floortime Method in Child Palliative Care System by 2 psychologists from Belarus, Anna Garchakova and DIR expert training leader Elena Akulova. And we also heard at that conference from Dr. Gil Tippy about good education, and in that he described how we now have produced a number of professions where people can't think. And he included doctors who aren't able to think anymore. They're just reading scripts of symptoms and prescribing based on that. He has written a book chapter about that, and we'll be hearing from him in the next few weeks at Affect Autism as well. But let's start out with Dr. John Carpente, who's going to tell us why this was interesting to us, because we would like to bring DIR Floortime to a wider audience and talk about some of the applications, particularly in palliative care. So John, why don't you start out?
Great. Well, thanks for hosting this. This is a great event. And it's really exciting because I think DIR just, there's misconceptions with DIR Floortime that it has to be only done with children and only autistics, and it means you're on the floor, and which folks that practice the model, at least I could speak for myself, that I don't think that it's specific to a client population or a client group. And I think what you pointed out, what Dr. Tippy mentioned about doctors reading scripts, and they're just focused on this prescribed way of being with people, almost like you're prescribing medicine, and that the relationship doesn't really matter in this medical model. And I think that we have a lot to bring to medicine. DIR is a way of being. It's a way of being with people. It's this way of being human. And floor time, although it could mean that you're on the floor playing in a conventional way, it's more of a philosophy. It's a philosophy that's geared around how to relate and communicate with people. And I would even say that beyond the clinical setting, just how we be in the world. And providing respect for other people's, I don't want to say for differences, for lack of a better term, right? And so most of the work that I've done with DIR has been with children, autistic children. And one of the things is the individual differences. What's getting in the way of this person's ability to relate and communicate through a wide range of experiences and emotions. And I could see that relating to anybody. So in the context of palliative care, what's happening with this person? Have they changed their identity now that they have this disease in their blood, or for lack of a better term, of course, but what's getting in their way of being relational, getting to deeper, more significant moments of relating and communicating, with folks, whether it's their medical team or their family members. And so this is where the medical profession, the nurses and the doctors, I think, can come in and train or coach while being with patients. As you said earlier, I teach at Malloy College in the music therapy program. I also run a clinic. But what's great about the college is that it's very interdisciplinary. I want to say specific, but it's very interdisciplinary in terms that there are many social service programs that are being taught there, specifically nursing. It's one of the top nursing programs in the country, and I've been fortunate enough to connect with them. And every semester, they ask me to come in and speak to their nurses, and they say that because they have the misconception too that it's something that, well, we don't really work with autistics. I said, well, whether you do, you don't. It's just another way of being, and the practice that's being taught at Malloy in nursing and beyond is more of a family-centered practice. So little did they know, it aligns nicely with DIR and Floortime, which is very family-centered. And so I had an opportunity, I don't know, I guess before the holiday break, to speak to the nursing students on how this model can be conceptualized in a hospital. Whether you're working in oncology or in palliative care, or even nurses that are working with the elderly, and how this can help folks who are afflicted with dementia or Alzheimer's disease. And so when people hear this, they're like, well, how can this be? We don't play with toys. I said, it's about relational dynamics. Because it is a form of psychotherapy, whether you're working with kids, teenagers, adults, regardless, whether it's a medical setting or a school setting. And so this forum today, I think, is really exciting, and I hope that it gets out there, to the masses, because it deserves an ear, or a voice, so to speak.
Well, thank you for being a part of it. And it blends in so nicely with what Dr. Ammons is thinking, and she is relatively new to DIR Floortime. Do you want to tell us a bit about what you do and where DIR Floortime fits in?
Hi. I would add to my hospice and palliative care background that I was a family physician first. I've been a family physician for over 30 years, and I chose that profession because I love working with families, and the dynamics within the family make or break circumstances of care level. In hospice, we're particularly working with a narrower group of people and families compared to palliative care. Palliative care is an umbrella over hospice care. In hospice care, we basically, to get coverage from insurance or Medicare, have to have two physicians, the hospice physician and the primary oncologist or other physician, saying that there is a prognosis or an expectation that the patient will only live for 6 months. This has actually got more elbow room to it than you might think, because it is not uncommon for us as hospice team to come in to a family situation and stabilize it, which, between that and getting people off the poisons they might be on because they're trying to kill a part of their body, can actually lead to much greater quality of life. And that's the focus I have. And quality of life, as John says, it's not just about people who have illness. It's about every one of us. And I got involved with DIR sort of sideways through my sister. And I took 101, which is the very first class, and I repeated it with another daughter of mine this December. And in November, I went crazy at the conference. And I got to meet some of these people and connect, and it really energized me. So right now in Montana, which I joke we're 10 years behind everywhere else, but we're actually sometimes able to sneak in new topics and trainings. We do have some palliative care. So when I talk about palliative care, we have a doctor who is, that's where the buck stops, basically. A nurse who does home visits regularly, social workers, and then a whole crew of aides, of we do have some musician thanatologists that do true end of life harp playing. We have a massage therapist. We do what do you call it? You do your essential oils that we bring into the home. We use everything we can, and we work with the whole family, because if the family dynamics are not stabilized, then you can't really take care of that patient well. So we're very family centered. It's what we do. And the beauty of the DIR Floortime is, just as John said, it's about us our whole lifetime, and it's about quality of life. And yes, physicians can get stuck on how we're supposed to communicate with people. And that is slowly changing. There's no doubt about it. And some of it would definitely be better with DIR Floortime training. There's no doubt in my mind. Trying to change medicine is like being Sisyphus and trying to push a big rock up a hill and not have it roll over you on the way down, and then keep pushing. So I'm excited to see people making those changes, actually actively making the changes. And I want to get on board. I just want to be on board. And neurodiversity couldn't be more true at end of life too. I mean, I am currently working with a dear friend who has Alzheimer's. He was a physician. He resisted treatment because he had this black and white thought. And now we are painting. We had an incredible celebration of his life with his whole family showing up, doing poems and stories. And this man went from not being able to complete a sentence to using metaphor and also making jokes. And he beamed the entire time his family was there. And it knocked me back because I was seeing him as someone who couldn't do those things. So I am very humbled by what I see. I'm very excited. And I can't wait to bring this to more fruition in my area.
Well, thanks, Beth. And that really goes to say, we look for the why behind the behavior, and we always presume competence in DIR Floortime. And as you just mentioned, it's easy to forget about competence, especially when you see someone declining. And so I want to bring it to Galina now to say, how do we bring this DIR Floortime to the medical model? And how do you see this kind of thing happening, and how does it look in your own social work?
Oh, thank you. I'm so happy to be here and to have this interdisciplinary discussion, because it's long overdue. And actually, I had a lot of thoughts when I heard what John had to share with his work with nurses, and especially what Beth was saying in her work in palliative care, because it so happened that I supervised Elena on during her putting together the article, and also I worked with another former student of mine from Latvia who also works in palliative care, and they also use this approach there. And they found out, first of all, they walked in and they found out that people are being objectified. And we, the professionals, we assume that that's an object that's in our care. We need to turn them. We need to roll them over. We need to change them. We need to. But first of all, we need to figure out what's happening with them. And yes, maybe they are in crisis. They are in this existential crisis when they are losing skills, children and adults alike. So we need to figure out what this tiny spark of interest is and treat everything that they pay attention to, everything that they concentrate on as their interest, and start with that. And in the social work field, we've been taught for ages how to do assessment, how to collect information, how to pay attention to body language and facial expression and general affect and this and that. And now what? What do we do with this information? So I think that DIR Floortime steps in with a very nicely packaged strategies where we finally know why we do what we've been doing. We need to use our mirror neurons to tune in with their affect. We need to trace their facial expression and figure out how to mimic it. We need to downregulate them if they're overly excited or angry or enraged or frightened. And how do we do it? DIR offers all of that. So to me, it's like John said, it's the way of life. It's the whole professional philosophy that will seep into other areas. But it's really important that we work together and we work on it as a team, and we can really make it happen with this holistic approach to a person, and also learning from other professions.
And what I heard you describe there were a few of the key principles of DIR Floortime, which is meeting the patient where they're at. And we talk about that as meeting at the developmental level that they're at and following their lead. So what is it that's going on with them? What is their emotional interest? What are they paying attention to in that moment? And then moving them up the developmental ladder, because you mentioned that they may be focused on, the grief of losing their skills that they have. And I know you mentioned following their lead, it not only physically, cognitively, physiologically, all of these ways to tune into them on this emotional and physiological level and try to bring them up. And John mentioned and Beth mentioned as well the relationship. Like DIR Floortime is all about the relationship, and how do we manage what gets in the way of that? And that's what DIR Floortime is. So John, how do you see that happening, where you're sort of coaching or modeling respecting everybody in the room and joining, and can families do it on their own, and how do you show them why they're doing it? And I think the important point too is it may or may not be something that we are able to teach, but it comes with clinical experience. Did you want to talk a little bit about that?
Sure. Yeah. Because those are great questions. I think just how we would work clinically goes into how we teach. It's hard to teach empathy, because when we say follow the client's lead or the child's lead, I think, I'm trying to meet their affect and then respond with spontaneous, true empathy, as opposed to a stock response, And so I think the participant who we're working with, coaching, teaching, plays a role. And it's something that they become their own agent. So I don't know if it's about, hey, when this person says this, you should do that. Because then we're just teaching them what to do based on what I would do. As opposed to then, what I like to try to do in training is try to help the trainee or whoever I'm doing this with gather an understanding of what's getting in their way of being able to pick up on this cue or being able to show more affect. Because maybe they have some challenges in those ways. And then on top of this, if there's a caregiver of someone in palliative care, they have these emotional challenges that are going that may need to be processed with. The thing that Galina brought up I really like and resonate with, and I think relates to this, is that how folks are being objectified, and I kind of equate that if we put it in a DIR context, it's like folks reducing people to their behaviors. So they're not people, they're behaviors, they're going to act out when they do this, or in the medical, maybe they're having in the medical context, maybe they're having an adverse reaction or response to something. So we're working more holistically. So how can we, I don't want to say change people's lens or trainees' lens, but help them expand their range of how they see things. And can they locate themselves differently, to see it through this lens or that lens, because we want to make sure we're responding, not reacting, and that the response is not based on our own need as a caregiver or a therapist, but the need of whoever we're working with, if that makes sense. So teaching this, I think I think instead of DIR, it should be RID, right? Because that is where everything is happening in the self-reflection process. I know when I'm a trainer in DIR, one of the things we try to facilitate or provide experiences, folks, I don't know how you can facilitate this, is how is the trainee self-reflecting? How can we facilitate self-reflection in this process? Because what they have to learn or understand is that it's a parallel process between them and whoever they're caring for. And if we can do that, and then as clinicians, we can only give as much as we are, as much as we know. And so I think that self-reflection piece kind of adds grist for the mill, if you will, when we're in, as Greenspan would say, cooking in this relational way of working with folks in whatever clinical context.
Yeah, and the key being that it's a process. And I've done a bunch of podcasts around process-oriented learning in school settings, but it's the same that you just described. It's the same where you're working with a family, and Beth, you can probably speak to this, working with families. It's a process. You described the process of your friend going from black and white thinking to, not being able to speak for a while to, getting to this point where, because of the relationship, because of the family coming in, because of the joining together and relationship, his developmental ladder increased to joking and using metaphors.
Yes, it's a profoundly strong way to bring quality of life to someone. And the relationship, I agree, John, it's everything. And it's to have that kind of really positive relationship, you do have to think holistically. And I happen to have always felt this way. So I'm an easy person to jump in and say, yeah, let's do this, but it's going to take some strategy, so to speak, to bring it to everyone else. However, one strategy is when I was on call last weekend, and it was a rodeo, I called it, because it was really challenging. We had really sick people and poor communication from the hospitals, and the nurses were in the crossfire. I floor-timed them. I helped them regulate. I was regulating myself because it was overwhelming at times. And it's very profound. And being able to see how powerful that is in my own life, in both personally and professionally, that's part of that reflection. And that's part of the power of it. Because I just think that in medicine, we are changing. When I first graduated, got my MD 33 years ago, a lot of my training was more, as you say, an objectification, but more an identification of somebody by their disease. Certainly not a holistic look at them. And I have never felt like that's the way to take care of people. So I'm fortunate enough to have years of experience as a family doc and as a hospice and palliative care doctor. And I really get this, and I really believe in it. And I am a neophyte. I'm just now taking the first 200 level course, and I'm loving it. And I think there are a number of ways that I can bring this to fruition. And it may start just with my interactions with the nurses.
And I wanted to point out for those listening on the audio podcast or watching on YouTube, At the full blog post at affectautism.com, if you search palliative, I will have a write-up with links to what we're talking about, including links to the Interdisciplinary Council on Development and Learning, the HOMA DIR Floortime, and the courses that Beth described taking. 101 is the intro course. 201, you achieve your basic certificate. So I'll have links to that, and there's discount codes at Affect Autism to take those courses. Galina, did you want to jump in on what you've heard?
Yes, sure. It goes right, it's up my alley because social work and psychotherapy, and Dr. Greenspan came that tradition too, is traditionally all about reflection, the parallel process, what it does to you, how this work changes you, what happens in the process, your own reactions. And we had this tradition of reflective supervision, the basic supervision or more advanced supervision, but it's kind of in our blood, in our professional blood. And in teaching courses, I'm just amazed to see how other professions come in, and for them it's mind-blowing. It's a change of paradigm. So I can go in and talk to my supervisor, not about the paperwork and not just problem solving and troubleshooting, but I can actually talk about how it makes me feel. Why is that important? Well, it's important because then you go back to that patient with all your baggage. And by doing that, it really changes your interaction with the patient. So knowing how to unpack it behind the door and walk in with something that is more patient-centered, I think this is the skill that is yet to be learned by so many professionals in the medical field. But I'm very happy, Beth. I wish you waited a little bit and joined my course that starts in February, my 201. But well, maybe some other time we will interact and work more. But this is really exciting that it seeps into the medical profession. I just got off the a session with a patient who was complaining how the medical professionals handled her COVID. And she was reflecting on how the very kind of dismissing, cold, okay, it's in your head attitude really affected her. And she spent next 6 months struggling with this concept of being defective. This is amazing what our words and our affect and our emotions can do to people. It can bring them up. It can treat everything as meaningful and help us capitalize on what we have, or it can bring us down, shut us down, and rob us of what we have. So they treated her as much as they could treat it, but also they took something away from her.
Yeah, and you made such a good point about affect. The reason the site is called Affect Autism, it's all about affect and engaging in that moment, and how you can turn that into, and you had said this before in a previous conversation, turn that into interpersonal excitement. And I loved the way that you termed it in that way, because you just described the opposite process where someone turns it into interpersonal devastation. I don't know what the word would be, but
the validation.
Yeah.
Taking something away and saying no. Mm-hmm. You see things and you hear things and you feel things that are not there. Very judgmental and very cold, and it cuts something off, and I'm sure that it cuts something off neurologically as well. Beth, am I right?
I think it also damages the caregivers. Physicians have an extremely high rate of suicide. And I believe very strongly that part of it is we have been told from long ago that we need to remain objective. And because of that training, we're spouting statistics. And when I was teaching in a family medicine residency, They weren't being told, wait, watch, and, get in there and see where they're at and join them. Not in those specific words. However, one of the reasons I taught was I felt that this was somewhat missing from my training. And the greatest difference I can make is when I work with young doctors and also nurses. And the problem is often that I think not so much in family medicine, but in some of the other specialties, there's this huge burden of knowledge that we're expected to have. And right now in COVID, we're being slammed. We're watching people die right and left, and we know that we want to do better. And so I think it's also about bringing this in for the well-being of the professionals as well. And once they can live that way, they will bring it into their doctoring.
Absolutely, absolutely. Uh, People need to figure out how they're going to replenish what they have, especially when they have so little with COVID. They have little to offer. Where do I go? Where is this resource? So Floortime, DIR Floortime offers that resource. That's how you can get recharged and come back with a little bit maybe, but come back with some emotional energy, come back with ability to tune in and work with the patient where the patient is at, and also work with the family, because families in crisis, they also need us.
Yes.
Maybe more than the patient sometimes, because like you said, and also in your line of work, you cannot probably do much for a patient, but you can do so much for the family. So the family comes in with a different attitude and different resources.
Yeah, we try to keep a really broad look at things. And because we know that how the patient is doing is reflected in the family and vice versa. So it is incredibly important to keep in mind the best approach that we might have. And it has to be able to change and adapt, because people aren't statistics and they aren't going to just sit there and behave in one way. And so part of it is, if we better understand why these things are happening, then we can better respond to them, which is what we want to do. I have incredible respect for hospice, my hospice team, and we meet once a week and review patients, and we all put in observations and suggestions. And it is the best medicine I've ever practiced.
And I really hear so many parallels between the work done with children, and I think Galina and John will agree with me that Beth could be an expert training leader the way she's speaking about it. You're a natural at this. The way that we work with parents. So sometimes the parents need the DIR Floortime more than the kids, and the support in how to relate to their children and how to accept their children for who they are, and how to respect the individual differences, and how to respect all the emotional experiences that a child presents, etc. And John, I know you had spoken a bit before when we were talking about getting this podcast together about what gets in the way of a robust relationship, and I wondered if you wanted to discuss a little bit about that.
Sure. Well, it could be the individual differences. It's when Beth pointed out when you were working with that gentleman, and he's able to get into more abstraction, and not only is that a milestone, but it deepens the relationship. You can get into a deeper level of that. But also, what might get in the way could be the clinician getting in his or her own way. And Beth, when you mentioned about adapting and whatnot, I think that's one of the trickiest things with Floortime, is being reflexive in the moment, and because that's like harnessing affect, and kind of always being there, but yeah, then having this understanding, this observing ego that's on your shoulder to check in and say, okay, whose need is this? Am I doing this based on the client or the patient's need, or is it my own? And so sometimes that can get, in our way, being able to provide a certain intervention. And then when do you know when to stop following the lead? Because if we just providing empathy can be done through a range of contexts. But it could also be the client, it could just be a catharsis, which is fine. But then sometimes we can take that and try to make it more reciprocal in a moment. It could be a learning moment there of, what is this catharsis about? So in turn, making it more about the in the moment, what's going on between you and me, as opposed to what went on between you and your parent or brother. Because I believe in this model, and again, it's not just this model, it's most relationship-based models, that what happens in the therapy room or the medical room or the treatment room is a microcosm for what's happening out, outside of that. So I think, to sum up, what gets in the way of robustness is getting a better understanding of the eyes. And mostly times with kids, it could be sensory challenges and how how the person's taking in the sights and sounds. And then folks that maybe have more control over their sensory systems, it could be emotional challenges and what's going in at that moment. But I just think, all in all, though, it's the clinician's responsibility to know his or her individual differences too, because that can get in the way. And that's the self-reflective piece that I think we all chatted about earlier.
And also just people's defense mechanisms that come up. Something gets triggered in you that you didn't expect to be coming, and how you can reflect on that. I know, I think it was John had given an example before this podcast. If someone's in pain and they throw a bedpan at you, it's not about you. And how do you reflect with that?
Or it could be because you're not listening. Mm-hmm. And so it could be a form of communication, right? So we have to figure that out, I guess, right? That's, yeah.
And not all defenses are bad. There are times when it's how someone is sort of holding on to their truth. And I think it's really important for us to understand that their truth is important, and we're not going to correct them or somehow try to get in their head and prove we're right and they're wrong. And I think that's part of the sticking point for a lot of physicians and nurses. I think our training still puts us in that role of being the expert, when in all truth, every pregnant mom and every baby that I took care of for years and years, I would say you are the expert on what's happening for you. And unfortunately, that doesn't always happen. And it may be time, you're getting crunched, you have 10 more, 15 more patients to see. But I do think there's ways to relate that can adapt to that. Again, adapting.
Well, it couldn't. You said the most important thing here, and I want to second it, that yes, parents are the experts, and yes, sometimes we start to treat parents without them asking us to treat them. So this is really important to remember the boundaries and to know that they did not come here to be treated. They came to explore with us how their child can be helped. And this is the road of exploration, not treatment. And not every treatment needs to be about breaking something down. Like you said that defense mechanisms, yes, they're like a storm door. The defense mechanisms defend us. Yeah. We need them. Like we need some anxiety in our bodies. That's our survival mechanism. We need some of those things. And it's a very delicate dance, how we balance it. And it's not a nice way to, come running for help and break somebody's storm door. They probably won't be happy to see us. So we need to find some other ways of getting in and helping them down there. So working with the defense mechanisms, not against them, not breaking down, and not breaking down parents as we try to help children.
And bringing hope to the situation. I think often that is not a focus, or it's a focus in a way that, doctors are like, well, the prognosis is, X, Y, and Z. But I have seen over and over again in my work as a doctor that hope is powerful. It's powerful. It allows change and adapting for all of us. And I think that's an important key.
I think to piggyback on that, I think hope and empowerment, especially I can use my own experiences when I go into a hospital and you feel so helpless because I don't know medicine, but I know people, and I know what it's like when I feel connected with someone, a doctor or whatnot, and so that in itself, at least in my own experience, kind of empowers me, where I have control over something as opposed to, because I think there is a hierarchy, and it's utilized in the hospitals, not everywhere, but I think that happens, and where the patient is down here, and you saw Patch Adams, right? Come on. that Patch Adams is the epitome of this, and folks watching this podcast, I don't know, I'm dating myself, but it's really all about that, that you can be with patients in a more level playing field and still provide them with the medical care. And it's not about fixing them, because they don't need fixing. They just need some patchwork in an area that they can't, fix themselves, so to speak. But it's this process, of, I'm going to be with you along these lines, and how can I empower you during this process?
Yeah. I love that, John, because one of my mentors over the years was Dr. Rachel Raymond, who's done some amazing work training physicians and nurses and working with patients. And, one of the cornerstones that she teaches is called generous listening. And that generous listening is put that whatever's in your head behind a door and really be there, really be present, and recognizing also that your stuff gets carried into the exchange if you're not paying attention. And she has 2 books that are just remarkable, and I give them freely to all my professional friends.
And let me just loop in to say, Dr. Costa and I had a really good conversation about this a few podcasts back as well, about the reflection and how that stuff creeps in, and that needs to be part of the process and the training of professionals.
Yes.
And I mean, you guys were speaking about the hospital hierarchy, and the first thing I think about is the school hierarchy. I worked at the Ministry of Education, and you have, the students should be the priority, and then, the teachers may or may not think they know better, but then you have the people at the Ministry of Education, and it's in the States, it's the Department of Education, oh, well, we're creating the policies and we're mandating what the teachers need to do, and you have these hierarchical struggles when all of the things that are most important get lost, and it's the patient or the student.
Mm-hmm.
I also wanted to loop back to a podcast or a blog post done that I'll link to in the blog a few years back about how DIR Floortime is aligned with patient rights and the neurodiversity movement. So that was another blog post that we can link to. But before we wrap up, was there anything else? We covered so many different areas, but I think the larger topic and idea is, how do we integrate the DIR model into the medical field as well? We're already trying to do it in the world of autism, where Dr. Shanker's already trying to do it in the world of schools with his self-reg and how can we move it everywhere, but especially in this field of medicine, and as Galina pointed out, where Dr. Greenspan came from as a child psychiatrist.
Yeah.
So any last thoughts?
I think that Beth just mentioned something that can be the last thought is listening. I think Columbia University Medical School has this program of narrative medicine.
At which university?
Columbia. I think
Okay.
Columbia University Medical School has this program. I'm not sure, but most likely. And yes, this is the shift to be able to sit in with the patient and listen to the patient's story,
Yeah.
not the silent patient.
Yeah, in education, it is being pursued, especially I think in family medicine. It's sort of a natural fit there, but it's difficult. And part of the difficulty is the incredible demands on the young doctors. You know, how much they have to learn. They're on the hot seat. They're missing lots of sleep. And so when I was teaching them, one of the things I focused on is helping them regulate, because I felt that if they could regulate, then they could bring that in the room with them with the patients.
Yes, and maybe that's the way to change eventually, one day, to change and humanize the entire system. I started my career in a hospital. I know what hospitals are like. It's very demanding, very fast paced, and it's very easy to lose the patient along the way. Very. So, listening and adopting a model that will help us sit and be there with the patient, observe, and think how we can use this observation to our professional benefit, way it's going to propel the overall progress of the illness if we look at it from the illness and disease model. So yeah, it can be useful.
I think on a practical level, when you mentioned dairy, you know, how to make this happen, I think things like this podcast, I think awareness first, because I think, you know, DIR is synonymous, you know, it's with kids with autism, and I think the trainings then should focus on things like this, because that's going to attract people that work in the different, you know, say palliative care, hospice, or oncology, whatever it is. Because I just think people just have this one way of thinking about DI, and they should. It's our job, really, as the professionals, to get it out there. We have to do a better job. And now that, you know, Beth, that you brought this, I mean, that you initiated this talk, that's great. We need more folks within your discipline to come and do the trainings, and then become a trainer, and then create a course. But I think on a practical level, that's probably, you know, possibly one of the avenues that we can take. And I know it's exciting for me because I've always felt this way. But, you know, my clinical practice, although I've had experience in hospitals and working, you know, with different populations, but for over the past 20 years, I've been with kids and adolescents. And so I don't know the medical field as well, or these other areas, but I do think that it crosses through disciplines and crosses through clinical populations because of the essence of the model. So if we can get it out there and just create more awareness like we're doing now, that could be a good start. It's exciting. Yeah.
Yeah, and I do know that the executive director of the Interdisciplinary Council on Development and Learning, Jeff Gunzel, it has been very interested in bringing MDs into the model. So he was very excited to hear about Beth's interest, and who knows, maybe Beth will lead the cause. We'll see.
We'll see. I crawl around on the floor at 62 with my 13-month-old grandson and have a grand time. I'm up for it.
Well, thank you guys so much for being here today. Dr. Beth Ammons in Montana, Dr. John Carpente from the Rebecca Center in New York City, and social worker Galina Itzkovich in New York City. And I'm Daria Brown of Affect Autism. Be sure to check out the links at affectautism.com for a write-up, and there will be in the description a link to actually 2 publications that recently came out on this topic, which we didn't really get a chance to discuss much, but this was one that Galina was involved in, DIR Floortime, non-directive method to help improve communication and develop emotional intelligence. And the one that was from the conference, the implementation of the DIR model and DIR Floortime approach in the system of palliative care for children, that was presented at the ICDL conference. So I'll put links to both of those as well on the website.
Yes, and I just want to add that the publication came out in the journal Mental Health Global Challenges, and we are very much DIR minded, and those professionals who want to submit, please remember to submit articles to Mental Health Global Challenges.
Thank you. Yes, Galina's on the editorial board. So that would be great. We always need more publications around DIR Floortime. Thanks again. I can't thank you guys enough for bringing this to the audience.
Thank you for having me.
Thank you.
Thank everybody.
If you're a caregiver looking to implement your own Floortime approach, please check the ICDL parent website at the Interdisciplinary Council on Development and Learning for a virtual Floortime consultation or for the weekly parent support meetings. We aim to help you implement your program at home using the Developmental Individual Differences Relationship-Based Model, or DIR, taking into account your child's developmental level, their individual differences, and using your relationship with them to help promote and support their development. Until next time, here's to affecting autism through playful interactions.